Hello everybody, welcome. My name is Francesca Tentori. I'm a nephrologist here at Arbor Research and a senior research scientist who works on the DOPPS. I'm going to present to you today some findings related to secondary hyperparathyroidism from the DOPPS study. Very briefly, the study is an international study of dialysis practices across the world, and we're currently in more than 20 countries. Today, we're going to talk specifically about recent trends in parathyroid hormone levels and outcomes in this population. As a background, there have been several studies indicating that elevated PTH levels might be associated with adverse clinical outcomes in dialysis patients, as well as low levels also having been shown to be a detrimental risk factor. There have been no randomized controlled clinical trials, so the evidence supporting clinical practice guidelines is considered weak. The KDIGO guidelines that were published in 2009 recommended a PTH target level that is considerably higher compared to what had been previously indicated by other guidelines. As you can see here in a summary of guidelines across the world, the target levels have consistently increased in all regions, with the exception of Japan, that currently has the lowest target of all the regions where DOPPS is currently ongoing. So based on this, and based that clinical targets have become more liberal, we were interested in reporting trends in PTH levels and therapies related to PTH over the past 15 years across DOPPS countries, and to investigate the association that PTH has with mortality and hospitalization. In this figure, we show the distribution of PTH levels across DOPPS regions that are listed at the bottom and over time. So the numbers indicate DOPPS phases from the first phase, which was started in the US in 1996, to DOPPS 5, which is the current phase with data through 2014. If you just concentrate on the horizontal bars, you see how the median PTH has increased constantly both in Europe, Australia, and New Zealand, which is the first region to the left, as well as in North America. And this has been a significant increase in both of those regions. In Japan, on the other hand, the levels, as you can see, are much lower, and there hasn't been any significant change of levels over time. One interesting thing is also to notice at the upper level the high proportion of patients, about 5% of patients with extremely elevated levels of PTH. So for example, in the US, 5% of patients would have PTH level above 1,000. Also of interest, for example, in the US is that there are high proportion of specific patient subgroups with very high levels. For instance, approximately 30% of African American patients had PTH levels above 600. And this trend in increasing PTH over time has been constant, irrespective of serum calcium level, serum phosphorus level. So whether the calcium and the phosphorus were high or low, the trend towards higher PTH level was constant. And the same for patients of different ages or different duration of dialysis. So it appears that these physiological factors did not contribute per se to the increase in PTH, but rather that other practices had an impact. And what we postulated was that the change in clinical practice guidelines was one of the major driving factors. In fact, in the DOPPS, we ask of medical directors at the unit to indicate what target levels they are currently using. And this is how the reported target levels changed over time. If you see the phases again, is time in DOPPS, and then the different levels of PTH. If you just concentrate on the greater than 600, you see a progressive increase from 3% to 24% in Europe, and from 2% to now 42% in North America, consistent with the change in clinical practice guidelines. So most medical directors in those two regions indicate that they're now pursuing much higher PTH levels. There really has been no significant change in Japan, as indicated here. Obviously, the way we have a direct impact on PTH levels is through treatment, and so we look at trends in secondary hyperparathyroidism therapies, in this case specifically vitamin D. This includes oral and IV vitamin D in the blue bars, and as you can see, the prescription has increased dramatically in most regions, including Japan. There has been definitely an increase in the intravenous administration of active vitamin D that is indicated by the blue line. Another way to treat high PTH levels is obviously cinacalcet. It became available at some point during the third phase of DOPPS, and it has the use of cinacalcet has steadily increased in all regions, reaching about 20-25% in the most recent time point. Another way to control high PTH is the surgical removal of the parathyroid glands. That used to be relatively common, and as you can see, these are parathyroidectomy rates over time. Those have fallen dramatically across all DOPPS regions, including Japan. What we postulate is now we have alternative pharmacological treatments that might not be as invasive as a parathyroidectomy, and that those are being used more commonly compared to the surgical removal. And we actually demonstrated that in our prior slides. The next question, of course, is does it matter that PTH levels are increasing? And we looked at very fine categories of PTH and the risk for mortality. All-cause mortality is in blue, cardiovascular mortality is in orange, and each of these represent hazard ratio and the 95% confidence interval. So as you can see, the risk for mortality starts to increase at PTH levels of 300, and then it's statistically significant and very high for patients with PTH above 600. And I think it's notable that in the overall DOPPS sample, which does include Japan, we had about 11% of patients in that category, which indicates there is an opportunity to improve, given that above 600 is also not supported by current clinical practice guidelines. We were interested in looking a little bit more at the different cut points, and so we ran separate models looking at PTH greater than 300, greater than 450, and greater than 600. And the specific models indicate quite clearly that this risk starts to increase already at a cut point of 300, which coincidentally is consistent with the prior KDOQI target of 150 to 300. Obviously, DOPPS is an observational study, and while we adjust for a broad number of covariates, there is always the possibility that our findings are biased by unmeasured confounders. One way to take this into account is to use a statistical approach that is called instrumental variable, and results of such approach were very consistent with what is shown here. And more specific results are reported in our paper. We also look at the risk of hospitalization, and again, we saw an increased risk for PTH level above 600. Finally, we were interested in looking at whether the treatment used to modify PTH level might be one of the modifier of this association between PTH and clinical outcomes. And so here we studied the association between PTH levels, mortality in blue, and hospitalization in orange among patients who had not received any vitamin D, cinacalcet, or did not undergo a parathyroidectomy for the prior year. And so these are patients who did not receive any treatment. Still, the association is very consistent with, compared to what we reported for the overall cohort. Obviously, the number of patients are smaller, but you see a U-shaped curve as we previously showed. So just to conclude, PTH levels have increased dramatically in most countries, with the exception of Japan. We've also reported a change in the treatment for secondary hyperparathyroidism with an increase in vitamin D use, an increase in cinacalcet use since it became available, while parathyroidectomies have declined. We postulate that the changes in PTH is not driven so much by the change in treatments, given that these are all effective treatments, but rather by the fact that medical directors and clinicians are targeting higher levels. And that was confirmed by the findings in the DOPPS medical director survey. In this paper, we confirm findings from prior analysis, both in the DOPPS and other data sets, that found that both very low and very high PTH levels were associated with adverse outcomes. At the high end, certainly PTH above the current target of 600 have a very strong association with both mortality and hospitalization, but the risk already starts to increase at a level of 300. So I think these findings just contribute to the uncertainty, in the sense that in the absence of a randomized clinical trial randomizing patients to different level of PTH, there is pretty strong evidence from observational studies that PTH levels, even starting at 300, might have a detrimental impact on patients' outcomes. We hope that our findings will contribute to the development and update of future clinical practice guidelines, and I hope I have provided some useful information for your own practice.